The broadcast is now starting. All attendees are in listen-only mode.
Thank you for joining us today. My name is Stephen Aquario with the New York State Association of Counties. I'm very pleased to be with you here today. This is the third in a three-part series on combating the COVID-19 pandemic in the state of New York. Earlier this week, we did a session on wastewater treatment and how to identify the RNA of COVID-19 in wastewater. And it was a fascinating session, and hopefully our viewers today that see this presentation can take a look at the tracing, if you will, of COVID-19 through wastewater to help with public health and environmental health surveillance. And that is on the NISAC website as well. In addition to that, we did a session yesterday on contact tracing 101, the basics, how to understand contact tracing, how does it work, and the expansion of it, the traditional model with which local health departments use each and every day, and the expansion of it to address the COVID-19. And today, very pleased to have our panelists with us here today to talk about diagnostic testing. Our first presenter will be Dr. Gail Burstein, the Commissioner of Health in Erie County. Dr. Burstein is the Commissioner of Health and a clinical professor of pediatrics at the Jacobs School of Medicine in Buffalo, New York. Dr. Burstein is currently devoting Erie County public health efforts, of course, to control, combat, and reduce and eliminate COVID-19. Our next speaker is Rebecca Kaufman. Rebecca is the Director of Public Health for Broome County. In this role, she oversees all the facets of the local health department, and over 40 programs to ensure the health and safety of the public in Broome County in the southern tier of New York. And finally, very pleased to have Nancy McGraw. Nancy is the Public Health Director in Sullivan County, which is a partial services health department serving a population of 76,000 in Sullivan County, New York. Nancy has 20 years of public health experience and has been the public health director since 2013. I want to thank the New York State Association of County Health Officials, NISHO. The efforts led by Sarah Ravenhall and the very capable staff at NISHO has been tremendous, not just during this pandemic, but for the past several years. Noticed a dramatic effort by NISHO to protect the public health infrastructure of the state of New York and to really call attention to why local health departments are so important. And that effort and that awareness has been increased by its leader, Sarah Ravenhall, and I'm very grateful for the partnership that the New York State Association of Counties has with the New York State Association of County Health Officials. It's probably almost 40 to 50 years old together, working together. So a very special thank you to Sarah Ravenhall. So today we're going to talk about testing, COVID-19 testing. Of course, we've heard an awful lot about this from the President of the United States, from the Governor of the state of New York, the Governor of California. We hear it on the news, Dr. Fauci, Dr. Birx. It just seems to be an endless topic. It's kind of a complicated topic about testing. And so we hope today to talk a little bit more about this in depth, to try to understand the different types of testing. There are many testing, antibody testing. There's diagnostic testing. There's the short term, the short swab testing. There's the finger prick test for antibodies. There's the longer nozzle that's used, swab, if you will, that's used, and that was pretty funny if you didn't see Chris Cuomo and Andrew Cuomo on CNN. It was rather amusing, the joking around between the two brothers about the types of swabs and how it is used. And of course, the governor of the state of New York showing himself the other day in front of millions of people, tens of millions of people, just how easy it is to get that swab. But this is no joking matter. This is a very serious effort to test individuals. Of course, testing and tracing of that individual and isolation all have to work together. So let's get at it. Dr. Burstein, we'll start with you. Population just under 1 million people. That's a pretty large populace. That's a pretty large population serving a huge area of Western New York State. Let's go to you. Thank you, Dr. Burstein.
Sure, thanks. So I'm Gail Burstein. I'm the Erie County Health Commissioner. And so today I'm going to talk about testing for COVID-19. So I know it's a little bit confusing. As Steve mentioned, there's a lot of different tests out there. So I'm going to try to help you understand the difference between the two tests. So first, I'm just going to give you a little bit of overview of Erie County, and then I'm going to give you an overview of the different types of testing that are available currently for COVID-19, and then I'll give you an example of like how us as a large county with our own public health lab have been using these tests. So first of all, the background of Erie County. So as Steve said, we're a pretty large county. We have almost 920,000 people, and it's a very diverse geography. We have both urban, suburban, and rural communities. So it's a little bit tough trying to juggle how to meet all those needs. We are fortunate. We have a super public health lab. It really rocks. Carlene Pope is our public health lab director, and actually our lab is part of the CDC's laboratory response network. So we get access to really cool, innovative, pushing the envelope CDC tests before other labs, even before other commercial labs. Next. So first I'm going to walk you through what's the difference between a diagnostic test and an antibody test for COVID-19. So first, let's talk about diagnostic testing. And what's pretty much commonly available on the market is a test called, or you might have seen it, PCR. It stands for polymerase chain reaction. That is a nucleic acid amplification test. So it tests for parts of DNA or RNA. Remember the nucleic acids back to your biology, for any different types of bacteria or viruses. So this is a specific test looking for DNA or RNA, depending on the test, of the COVID-19 virus. And so a positive result means at that point of time when you had the specimen collected, that they found a COVID-19 RNA or DNA in your respiratory tract, and probably in your nose. Sometimes people are able to produce saliva, spit to get tested. Sometimes people have a very invasive procedure so they can get fluid from the lungs to test, but most of the times it's some type of nose swab, even a short one that Steve mentioned, or a long one is usually has the better performance. And so it's looking for active virus at the time that the specimen was collected. Again, a positive result, that would mean that we're assuming that you have an active infection, and then public health would jump in and we make sure that the case was put in isolation, and that the public health workers started an investigation, found out who the contacts were, and then notified them and put them in quarantine and offered them testing too, as opposed to an antibody test. So an antibody test means that if your test was positive, that you have antibodies to COVID-19. So that means that sometime in the past you were exposed to COVID-19, your body reacted and developed antibodies that test is detecting. So we don't know a lot about what this positive antibody test means. We don't know a lot about the antibodies yet. We're hoping that it offers some protection. We don't know that for sure, but there is some evidence that's starting to be generated that suggests that there is very likely that we will have some level of protection, although we don't really know how much and we don't know for how long. So you shouldn't do anything different than if you have a positive versus a negative antibody test. So it's right now it's a blood test. Most of the tests available on the market are through a venipuncture. So you have to give out your arm and take some blood. It only needs an ml, small amount of blood, but it does require a needle. I think there are some tests out there that just are like just a little finger prick test. There's a new rapid test that just became available last week that just uses a finger prick. So, so this test should be done, since it's looking for antibody response, so it should be done at least 3 weeks after the onset of symptoms, because you're looking for an antibody response, you know, as a result of an infection. So you want to have time for those antibody levels to mount up so that you can detect them. There can be false positives and false negative results, just like any laboratory test. So you just want to make sure that you wait like 3 weeks until after you had symptoms, if you did have symptoms, before you check for antibodies. And also, you know, there's a lot of shadiness out there with these rapid tests, so just make sure that this is an FDA authorized test. Next, please. Okay, so this is a graphic that was published in JAMA very recently, and I know it has a lot of lines and it might freak you out, but I tried to call out the lines that you should pay attention to, so you understand when you would expect to see a positive PCR test looking for DNA or RNA in the nasal pharynx from an active infection versus when you would expect to see an antibody test being positive. So on the left-hand side in the gray is what you would expect to see before the onset of symptoms. And then the right-hand side of the graph in the green is what you would expect to see after the onset of symptoms if somebody has symptoms with COVID-19. And then along the x-axis, it corresponds to weeks before and then after the onset of symptoms, and along the y-axis is the level of you know, the amount of either virus or, you know, DNA, RNA, or antibody that can be detected. So the 3 lines I want you to look at, first is the red line, and that is looking at where the virus, how much virus would be in your nasopharynx, your respiratory tract when you have an active infection. And you can see that there's almost a week before, or actually a week before people do start to develop symptoms, where actually people have virus in their respiratory tract or their nasal pharynx, and they are shedding virus and they are contagious. So, you know, that's why we recommend contact tracing. The history starts before the onset of symptoms. And then the next line I want you to look at is the blue line. And that's when the test would be able to detect either the DNA or the RNA with the PCR test to see if somebody is actively infected. And so you can see that the DNA, you know, should become very detectable. The levels are very high, actually right at the onset of symptoms. And then the tricky thing is that these the DNA RNA levels like persist to be, you know, very, very high even after the active infection period is over. And so the take-home lesson for that is, we know that CDC offers a couple of strategies for one to be released from isolation, and one is a test-based strategy. So the flaw with that is that even though somebody is over their acute infection with a virus, they still could have like remnants of DNA or RNA hanging around in their nose that would be detected by this test. And so it doesn't mean if you find the DNA or the RNA like 3 weeks after the onset of symptoms that you have an active infection. It just means you have like dead DNA or RNA in your nose. And so that's the flaw with using a test-based strategy to release yourself from isolation or to return to work, is that this test could be persistently positive for a month or more in some people when they may not actively be infected and shedding virus. So that's just something to keep in mind. And then the green line that I want you to look at is when you would start to see the detectable levels of IgG antibody. So IgG is kind of the long-term, you know, protective antibody that we all want to build up and have and protect ourselves against bacteria or viruses. And so you can see that the antibody levels just don't even start to pick up until and more than a week after you know, somebody has had an active infection, as somebody has had the onset of symptoms. And then they you know, they can pretty much everybody, you know, should be able to be detected by week 3. That's why we recommend that, you know, people wait for at least 21 days after the onset of symptoms before they get an antibody test. And then these antibody levels should persist high, and hopefully that it means that, you know, people have a good level of immune response, and hopefully they will be protected against reinfection. So that's what we hope. Although, there are other bacteria and viruses that we get more than once in our lifetime. Like we've all had strep throat more than once, right? And people can get influenza more than once. That's because the virus mutates. So, coronavirus is a novel virus. We don't really have enough experience with it yet to say what's going to happen. But these are all possibilities. So just don't get a false Social Security if your antibody test is positive. You can celebrate, but just kind of limited. Okay, next. So I hope everybody understood that complicated graphic. So let me just talk about our journey with testing. First, since we are in the Laboratory Response Network for CDC, we did have access to the CDC lab and to Wadsworth Public Health Lab early on, and then we were able to get our own test of the CDC's tests delivered to our own public health laboratory. So in the beginning of March, we were starting to be able to collect nasal swab specimens, and we sent them both to CDC's lab and to Wadsworth lab. And then in the middle of March, we were able to get our own laboratory test in our own laboratory. And so we started doing our own testing in our own laboratory. So we were able to finally get some reagent to be able to do the test, the chemicals needed to do the test, which was a struggle because there was this huge national shortage and CDC was like allocating distribution of this. And then another challenge that we had was the swab availability. I'm sure you're all experiencing that in your counties, that there is a national shortage of these nasopharyngeal swabs. And so now people are using other swabs, like nasal swabs that are shorter, but there's still a big, huge shortage. So, we started, since we are a regional public health lab, when we first started, we were not only doing laboratory tests for our county, Erie County, but we were also doing testing for the surrounding counties. Next, please. So, we have always been following the CDC and New York State guidance for testing criteria. So again, first when there was a very limited amount of testing because we couldn't get reagent and we couldn't get swabs, we started off just testing, back in the day, remember when travel was a thing? So we were just, testing people who had travel or close contacts to confirm cases that were symptomatic. And then as testing availability increased, we were able to get more reagents. We were able to get more nasal swabs. Thank you, Wadsworth. Thank you, Governor Cuomo, for these assets. We were able to expand our criteria for testing. And so then we were able to expand to all essential workers, especially healthcare workers, but also fire, police, EMTs. And then now we're at the point where we've been able to expand to include, anybody, whether they have symptoms or not, who feels that they are at risk of COVID-19 and, for whatever reason, we're able to test them. Next, please. So what we're doing now in terms of scheduling our testing is we have a call center. Unfortunately, we have been struggling to get an electronic platform available to make these to scheduling these tests. So we're still dependent on phones. But however, people are getting scheduled. We have right now we have 5 specimen collection clinics every week, and we're rotating through different parts of Erie County, make sure everybody has access to them. If we get a call like the day before or the morning of a clinic and someone's like symptomatic and they've been in contact, they're an essential person to be tested, we'll make sure that we get them in last minute. Right now, our public health lab is running between 100 to 120 specimens per day. This is a really long test. It's very difficult to perform. It takes a long time to perform. There's some other tests out there that are much more automated. So when we're trying to get our hands on one of those. And so we are always still working to thinking about how we can expand our testing capabilities in Erie County. We have some really smart people in our public health lab, so we're figuring out how to get that done. Next, please. So now I'm going to talk about what we're doing with antibody testing. So we were able to purchase in last month the Abbott's the COVID-19 IgG antibody assay in our public health lab. So now we're able to do our own antibody testing. So, we felt very confident with this particular test. I know that you've probably heard on the news, there's some FDA authorized antibody tests that have been determined, not to work so well, including with the test that the White House was using. But we feel very confident with our Abbott test. We've actually been using this test for syphilis serology for quite a while, and it's performed very well for testing syphilis. And so now we're using the Abbott's COVID-19 serology test to look for antibodies for COVID-19. So Mark Polenkars was very generous to our public health lab, and he was able to allow us to purchase 100,000 tests. Of course, we don't have these all in our public health lab, but each week we're able to order more for a maximum of 100,000. So we're going to be in this for a long term. We did a beta test a couple weekends ago with just Erie County personnel. So we figured out how we did the scheduling and collecting the specimens, because it is a full blood draw phlebotomy in the arm. How the public health lab was able to process these, because remember, they were still doing the PCR test from the nose swabs. And then we mail out the results, because it's not a critical result. You're not really going to do anything different based on the test results like you would with a PCR. So we actually mail out the results with the U.S. Postal Service. And we also provide some information about how to interpret those results. Next, please. So we've actually rolled this out to the public now. And so we've been doing this for about a week. And as soon as we opened up our phone lines, there was this huge demand of people wanting the antibody test. It's like the new thing. Right now, we're offering specimen collection clinics, again, throughout Erie County 3 times a week, and we're rotating locations throughout Erie County. So hopefully by the end of a month's time, there'll have been an antibody test clinic near everybody in Erie County. We're able to collect 500 specimens in each clinic. Actually, yesterday we had a clinic and we collected 530 specimens. We're again, scheduling through our call center. We're hoping that in the near future, we'll be able to get this automated online. And then again, we're mailing the results in 7 to 10 days. Next, please. So what we are offering antibody testing to is any Erie County residents that are ages 11 and older. So we're just limiting it to Erie County residents, because we're also collecting some epi data. We're getting, in addition to demographic data, we're getting a history of symptoms, and we're also getting a history of where people are employed. We want to know where healthcare workers more at risk of having antibodies than say, other people that have not been essential employees. So again, this is really more for an epi investigation, just looking at the proportion of, trying to estimate the proportion of Erie County residents that have been exposed to COVID-19, which we believe is very low, and there's still a lot of susceptible people. And then also if there's any type of associations with, work or symptoms or something else. So we found at these pop-up sites that it's it's pretty easy to collect the specimens. There's also a lot of other laboratories in Erie County that are able to do this test, because it's just a blood draw, so you don't need any special PPE, because you're not doing any type of specimen collection that would produce any type of aerosol with COVID-19 in it. So, any healthcare provider can order a lab rec for people to go to a commercial lab like Quest or LabCorp or BioReference or something else to get the blood drawn and get a test. Also, we know that a lot of urgent care centers, a lot of hospital systems are also collecting specimens and able to test people for COVID-19 antibodies. So I think that's a pretty easy test to do, and there's a lot of availability there. Next, please. So we have one asset that we just have put up for Erie County, and that is a map of where people can go and get a test. So where people can go and get a test, of course. So this is a map of Erie County, and then the purple stars are where people can get a test. So you look at the map, you can put in your address, and it'll do a search of where these testing sites are near you. So can I have the next slide, please? And so here I've clicked on a site in Orchard Park, and it pops up, what the name of the site is, what kind of tests they're doing, what their hours of operation is, and so you can decide if this is something a place where you want to go to or not. And it also talks about whether you need healthcare provider prescription or not, or if you need to be in any special category of individuals that could have been exposed either through work or have symptoms. So this is a great asset that we just put up to make things easier for Erie County residents to get tested. So I think those are, so just the next slide, please. And then these are just the websites where we have some great information for Erie County residents or anybody that wants to peruse through our website about COVID-19 and about testing and our data, you know, with our positives and our hospitalizations and our map for a diagnostic test. So that's all I have. I don't know if we're taking question now or at the end.
We'll take questions at the end, Dr. Christine, but that's all you have. Well, that's an awful lot that you just said. It's going to take quite some time to digest and think about the many things that you said. I know myself, I'll be watching this webinar again and again to follow those charts and graphs and bars and really think about a lot of the things that you said. Folks, questions, please, we have a question box on your screen. We'll get those questions after the 3 presentations. Please type in your question right into your screen, the question prompt there, and we'll pick up those questions at the end. Let's go to Rebecca Kaufman in Broome County. Broome County, of course, just under 200 or just over 200,000 population in the southern tier, located in the southern tier and the Pennsylvania border. I'm sure that you have been looking at Pennsylvania, thinking about Pennsylvania, how the counties of Pennsylvania are handling local health matters, seeing if the testing, diagnostic antibodies are matching each other, mirroring each other there. Also working very hard on nursing homes and trying to test your own public county-owned nursing home and all of the nursing homes within Broome County. Not an easy task to do. Also having a stand-up site at SUNY Binghamton, serving the population. Can you tell us about the diagnostic testing procedures and what folks can learn around the state, even around the country in Broome County?
Yes, thank you. So I was just going to basically go through our last few months of testing capability here in Broome County. So we started out just like everyone else, I think, not realizing that we would quickly have a shortfall in the amount of tests that we could have. So we started out with testing both in primary care offices, walk-in clinics, and of course our emergency rooms. But like I said, quickly we realized that as testing ramped up, we were running out of swabs, running out of testing capabilities. We do not have a public health lab. So to get testing done in Broome County, you go to one of these providers, they swab you, and then they send the swab to either Wadsworth in Albany or a commercial lab that they have a contract with. So this started to quickly become a problem, and slowly all of the tests trickled to our emergency departments. So they were handling it all on their own. Some of the commercial labs in the beginning were taking a very long time to get test results back. So anything from 5 to, I think the worst one reported to us was 21 days to get a test result back. So as you can imagine, by 21 days, the person is really many times feeling better and, calling us wondering where exactly their test result is. I think an important thing to note is the Broome County Health Department doesn't actually do swabbing. So we've done very few swabs. We are more coordinating where someone can go to be swabbed, and then obviously we get the results and follow the contact tracing. So thankfully within a few weeks, it seemed like a long time, but it was really 3 or 4 weeks, the state started having more tests on hand, and those would be brought to our emergency operations center, and then through logistics we were parsing them out first to just those emergency departments, and then quickly to nursing homes and emergency departments, and now we're at the point where we're able to provide them to other providers in the community as well. And our hospital systems, both Lourdes and UHS, have now been able to acquire testing materials pretty much on their own. We still are supplying them, but they have, gotten other tests on board that they're using, the rapid tests, and a lot of the supplies needed to do that. So that was good news for us. We did just, I believe, about 3 weeks ago, stand up the Binghamton University testing site that is completely run by New York State. You do need to either be general population with symptoms or an essential worker to be tested there. It's an appointment-based place. We have had a few questions about whether they would test the Pennsylvania residents, which Steve had brought up in the beginning, we're very close to Pennsylvania, and so a lot of people actually come to Broome County for care that live across the border. So we've been working through some of those issues. But just as soon as we tested, brought our capacity up to speed, the executive order came through that all nursing homes must test their staff twice a week. So that Binghamton University testing site is really spending a lot of time trying to help nursing homes meet that mandate. I do think they are still getting our general population in because we see people coming through there, but I also know a lot of the nursing homes tried to make that at least part of their plan. I don't think it's possible to make it their entire plan because you do need an appointment to go there. But it has helped us significantly and helped the hospital systems because at the same time they're now going back to doing elective surgeries and they're wanting to test their employees as well. So the Binghamton University site did come as a relief to our hospital systems to be able to kind of spread testing. Now, I will say one of the other pieces that I think is a little bit confusing is we have an initiative going on right now to try to test all nursing home residents at least one time. And the state was able to send us collection kits to do that. But because we don't actually have a lab here, we need to get those collection kits to a lab. And typically a nursing home doesn't send directly to a lab. They use our local hospital systems to take the swabs and properly package them and then send them off to the lab. Well, our two hospital labs could not keep up with both the amount of testing going on in their hospitals, their emergency departments, their staff, and then all of the nursing homes trying to test their residents at least one time. So there are many pieces to testing that I think have never really come visible, I guess, to the community because it was just a system that's always worked so well. But I think it is important to realize, like our local hospital systems that have always been able to manage the capacity of the nursing home testing, when we start putting thousands of extra tests on them, it's something they can easily become overwhelmed. And so we have worked and developed contracts with outside laboratories. We're helping to help nursing home workers learn how to package properly to be able to ship out specimens. And, this is the last, 2 weeks we've really been deep into nursing home testing. And, it's definitely, we have about 1/3 of our positive cases in nursing homes. So it's an important place to be spending our time. So we've had approximately 8,400 people tested here in Broome County, 466 positive people. And so it's been a big undertaking, but each week we're learning something different, focusing on something different, and that's basically where we are with diagnostic testing. In terms of antibody testing, it's just really in the last 2 weeks opened up here, and they do require that you've had some kind of symptoms to be antibody tested. So we have a federally qualified health center, Cornerstone Health, that's making appointments for antibody testing, and one of our local hospital systems with physician's orders, you can get antibody testing. So I anticipate that will continue to be more available because, like I said, it's only been up for about 2 weeks, but we definitely see people interested in both kinds of testing and continue to monitor those tests.
Thank you very much. An awful lot to digest there as well. It's complicated. The ability to bring antibody testing, taking shape now, coming into focus in the southern tier of Broome County, multi-states working together, understanding the regional effect in Broome County and that very complex long-term care system, senior living communities, adult care facilities, nursing homes. Twice a week, there's a lot to do. There's a lot of tests and processing that. It's a 2.5-hour ride to Albany to bring those tests. And I understand that your county is making multiple runs with those tests to Wadsworth each and every day. I'm very grateful for all the great work that you're doing in Broome County to protect the people. Thank you, Rebecca. Again, folks, if you have questions, type them into the question box, and we'll get to those questions at the end of our presentation. Let's go to Sullivan County. sort of in the southern tier, lower Hudson Valley area of our state, the southern area of our state, beautiful part of New York State, very historic. Used to be the Wash Belt, lots of acts there, comedians, musicians, speakers would visit there. Of course, Woodstock, a very famous part of the culture in Sullivan County. Nancy McGraw, you've done an awful lot in a very rural area, 70,000 population, right around that number, to serve your community. In the areas there, you've really used GIS mapping tools to understand this movement of this disease. You've done an awful lot with mobile testing and setting up those types of facilities and really trying to address the minority communities and language barriers, which is so important to help all people. Look forward to your presentation. Thank you, Nancy.
Thank you for having me. You described our county very well. We are in the beautiful Catskill Mountains, and though we're in the Mid-Hudson region, we really are unique from the other Mid-Hudson counties. We're about 76,000 population, and pretty much in the heart of the Catskills. We have lots of lakes and streams and rivers and mountains and a lot of outdoor things to do. So it's pretty hard for people to stay inside, that's for sure, especially now. So I'm going to just sort of paint a picture of, of the county and some of the challenges we've had, and then talk about the targeted testing that we've done in order to help contain the outbreak and reduce the number of new infections, and that's with our Latino population. So we have a whole team. We've had a whole lot of support, a lot of talented people in a very small county. And I do want to say that we're a partial services health department. So we also have the unique challenges of working with a large summer population of visitors, tourists, and summer camps. And those are regulated in terms of summer camps by the district office in Monticello. So we work very closely with them on any type of disease outbreak. And we had quite a few challenges last year with the measles outbreak. So there's a lot of additional challenges for a small partial services health department in a rural county that has a lot of diversity and a lot of influx in terms of visitors and population. So essentially we go from 76,000 year-round to almost 300,000, some would say, in the summertime. And so without a lot of additional resources. So I want to set the stage for that. Our first case, you'll see with our dashboard here, which was put together pretty much from the very beginning. And this really evolved as we decided what type of data we wanted to include and be very transparent with the public and make sure that everybody understood how the pandemic was impacting our county. So the dashboard includes, active cases, those who are on isolation. A lot of people focused really on the total confirmed cases from the beginning in terms of, oh my goodness, we went from, our very first case was March 16th, and it was in our county nursing home. And from there, it was all boots on the ground in terms of, we went from using our 5 epidemiology nursing staff to really quickly ramping up, hiring, pulling in all of our per diem nurses to additional staff. We hired an epidemiologist. We activated the incident command team with county leadership. We've pulled in county staff from other departments and helped to train them. And so we're really up to 20 and reaching towards our 30 closely with our contact tracing initiative. That's our goal. So we have a total of over 1,200 confirmed cases to date. And, we're tracking those who are off isolation. We've had 29 deaths. The majority of those are among the elderly, and like the other counties have had some challenges with our nursing homes in the county. We have 4. And total number of people who were tested in the very beginning, you know, as was mentioned before by Rebecca, that the rollout of testing in counties was very challenging in the beginning for a shortage of testing and supplies and resources. But by the middle of April, you know, we were able to really get that number up to where now we're over 6,000 people have been tested. It was a challenge to coordinate with other healthcare providers, although we did it very quickly to get the information out for the general public about where they could go to get tested in the county. We're limited in resources in a rural area in terms of access to healthcare on any given good day. But we have, you know, pulled everybody together in terms of the healthcare system, and all of our healthcare providers, for the most part, are providing testing. At first, they started just testing anybody who is symptomatic and you know, following the criteria set out by the state health department. That has evolved and increased and improved now that a lot of people can get tested if they're essential workers, and that list is expanding. So I'll go to the next slide. The demographics slide I put on here because I think it's important to understand when you compare rural counties in terms of their demographics in upstate New York and other parts of New York, a lot of the population mix has historically been primarily white and not Hispanic. And so we've got a lot of diversity here in terms of our percentage of Hispanic or Latinos, our percentage of Black. And that is true for our major towns that have the highest population. So we're going to talk a little bit about the town of Fallsburg, which is the area where we've been doing our targeted testing. Their percentage in comparison to the total county population of Latinos, which is about 16%, a little over 16%. The town of Fallsburg has almost 21% of Hispanic or Latinos. And we have historically had a migrant population there and a year-round population of migrant workers, not just migrant workers, but year-round residents who provide a lot of the employment and work in our various plants, which I'm going to talk about. Next slide. So we also have been using GIS mapping from the beginning to identify hotspots. And this is where we started to recognize early on that there was a growing number of positive cases in the Latino population. And throughout the county, this was very helpful from our GIS tax mapping department to really help us identify, you know, where are the most cases? Do we see clusters? Do we see hotspots? And this is really, you know, we had anecdotal information from people who were calling us, and we were watching the positive cases and trying to identify, are these people living close together in one particular town? Is it spread all over the county? So we really zeroed in on South Fallsburg. Next slide. We have in the county about 7 to 9 what we would call agricultural and light manufacturing businesses, which have been from the very beginning of the pandemic, you know, identified as essential businesses. So they range from food processing and packaging to poultry plants. The locals would call them, you know, our duck farms and our chicken farms, and a lot of, you know, there's a variety in terms of the types of light manufacturing plants that we have, and a really high percentage of the employees who are employed in these plants are from the Latino population. So I've listed them here in terms of when we started collecting data, and this is right through, I believe, the middle of May in terms of this data. It was a little bit of a challenge to gather the estimated number of employees that each of these facilities had. We did a lot of reaching out to them one-on-one when we started to see cases. We were not tracking place of employment initially until we started to see a growing number of cases in our Latino population. And when they went to get tested, they would anecdotally say, oh yeah, I work here, or I work there, and my husband works here. So many of the families had, you know, one or more spouses one spouse that would work in one plant and their husband or wife would work in a different plant. And so you can imagine if one of them tested positive and was exposed, they would be going to work to the other place. And so there was a lot of cross, concerns about people going to work while they were symptomatic, or even, as we know, you can spread the virus before you become symptomatic. So we felt that we really had some significant concerns on our hands. Of all of the plants that we were able to get numbers for, which was the majority, we've got over 1,300 people, and it's probably much higher than that, who are employed by these plants. And the percentage as of the middle of May of those who are testing COVID positive that we were able to collect the data for is about 10%. So almost about 150, 130 individuals that we know of who were able to get tested, that we were able to isolate and encourage them to stay home with some resources and all of the things that you need to do when you're in isolation and quarantine. So the percent positive of their workforce we tracked, and it ranged anywhere from about 4% to almost 16% in one of the particular plants. And so we had really early on reached out to these plants, to the operators, to the owners, and to the employees on both ends to really try to work with them and say, hey, we want to help you. We want to make sure everybody is safe and not coming to work sick. And what can we do to work together? Next slide. So this is one of our maps that we use to help us identify not only where people work who tested positive, but where they live, and try to make some kind of correlation to what was happening with the cases and the exposures in the town of South Fallsburg and the surrounding areas. And it was very helpful to visually see, a lot of people are very visual, and GIS mapping has been a tool that public health departments have used across the nation for decades. But as a rural county, sometimes we're limited on our resources, but we have a great pool of talent and a lot of people who are able to really stand this up quickly and to realize that this was a very valuable tool for us to use. Next slide. So this is just another snapshot of what we've used internally for identifying where people live in terms of those that were testing positive in this town. And as you can see, there are clusters in terms of 2 or 3, 4, 5 or more of people living close together. And when you think about socialization and interaction between families, especially in the Latino community, the culture is very family oriented and very social. And so it was really apparent to us very early on that we needed to do more in terms of grassroots advocacy to reach out to these families with some language barriers and challenges there, to make sure they understood what isolation means, that they should not go to work, they needed to stay home, that their exposures were in quarantine. What was the difference between isolation and quarantine? Just a lot of challenges. But this mapping really helped us to identify where and how we could do our outreach, our community outreach. Next slide. So this is a picture of one of our testing sites. We didn't stand up testing sites that were specific to public health staff initially until we started realizing, we knew that this population, and this is what we were concerned about, was that the Latino population historically have a limited access to healthcare and don't routinely go to primary and preventive care because many of them are uninsured, low income, and they really only go to a provider when they're really sick. And so they have a high utilization of the emergency room. And so we decided that we needed to really ramp up our testing and to provide it through public health, to offer it at no charge for targeted testing. And these are some of our staff. We've been doing it weekly. We're having our 3rd clinic today. And we'll be having, at least 2 or 3 more as we track and see how the number of new cases go. Next slide. So some of the challenges with the testing of the Latino workers in these manufacturing and light manufacturing and food processing plants, like I said, include language barriers. Majority of them only speak Spanish. So, it's kind of clunky sometimes to use the language line for our staff, but we do have bilingual staff. We had to pull in more bilingual staff from other departments. Also to use our community advocates. There's a Latino service providers group and a coalition, and the rural migrant ministries that we have partnered with to really reach out one-on-one with a trusted group in the community to try to get the word out, the education, to provide masks. There's historically been a mistrust of government interventions among the Latino population, especially the migrant workers and the undocumented workers. We have a few here, like every rural community. A lack of understanding of how the disease is transmitted, that was a challenge, continues to be a challenge. Crowded living and working conditions, poverty, like I said, limited access to healthcare, uninsured, lack of transportation, and that was really a key in terms of why it was important to us to reach out and do targeted testing. And then a fear of job loss and retaliation if they got sick and did not show up for work. We were trying to stress the importance of not going to work when you're sick, or if you have somebody at home who's sick and you've been exposed. So a lot of work has been done to educate, inform both the workers and the employers. Next slide. So some of the interventions, as I mentioned, is partnering on the grassroots level with our Latino community advocates, increasing translators, increasing outreach and education in Spanish. Sometimes it's difficult to get things that are in English from the State Health Department and CDC translated into Spanish if it's not already available. We use social media, Zoom meetings with the community, phone calls, and really let them know about our testing clinics that were available to them and why it was important for them to get tested. Distributing masks, face coverings as well as masks, and encouraging employers to provide them as a requirement of being an essential worker. Enforcement and education with the employers. We reached out and worked with the USDA, New York State Ag and Markets to do site inspections when we saw a growing number of cases initially, and anecdotal information from the folks who were getting tested saying, I have to go to work even if I'm sick. So that was a real concern of ours because we didn't want the community transmission to continue. That was really important to containing additional hotspots and the outbreak. We worked with the employers to make sure they had the guidance to essential businesses for cleaning, daily monitoring of employees, excluding anyone who was sick, taking daily temperatures, hand washing, break rooms, something as simple as not having a lot of people in your break room at any given time. Coordinating with our Emergency Community Assistance Center to distribute food, medicine, cleaning supplies to families who are on isolation and quarantine, and explaining all of that to them in Spanish. And assistance from the State Health Department for data analysis and consultation. We stood up our own Access database. First, we were putting everything into Excel, and then our computers started crashing after we got to about 500 cases, and we went to an Access database. So our IT department has been extremely helpful, and that is much more valuable in terms of analyzing and sorting data. So just a reminder that, public health departments, regardless of their size, have faced unique challenges, and our mission is to prevent, promote, and protect. And we've never been faced, in my lifetime with a pandemic that we've had to deal with, other than the H1N1 pandemic, which, certainly was quite different from what we're facing now. We had a vaccine then. We did a lot of clinics then, but we certainly did not see the level of fear, anxiety, and uncertainty that we're seeing now. So it's been a huge challenge. And that is my presentation, and thank you for having me.
Thank you to all of our speakers. Thank you very much, Nancy, and thanks to all our speakers. We are at just coming up on the hour mark here, but let's take a few questions that have come in. I'll just put it out there, and each of you, if you feel you have something that you would like to contribute towards this question, by all means, feel free to respond. If not, I'll just keep asking questions. Children testing. We're coming in through the summer months, summer day camp, governor canceling overnight camps during the summer months. These camps, summer day camps, are very important to many families for childcare, giving the children a venue to enjoy the outdoors, but at the same time, assist the parent as they work. Anybody have reactions about children testing? We've seen the potential for this virus to mutate or affect children in different ways than adults, and maybe 100 or so cases in the state of New York. Any reaction to testing of children?
Can you be more specific with your question? What do you mean about test? Should they be tested, or
children be tested?
If they meet the criteria for testing in a county, there's no reason why they shouldn't be tested. It's an easy specimen to collect. If they have symptoms or they're close contacts, there's no reason why they shouldn't get tested. And I've, as a pediatrician, I know that the American Academy of Pediatrics is really looking at the unanticipated strong adverse effects that kids not having access to school and then now potentially summer camp is having with kids with more depression, more anxiety, and more difficulty learning, being cooped up all at once. And I mean, hopefully we can think of a safe way to allow kids to be in some type of camp setting, and then in the in some type of school setting and still be safe. I mean, we know putting kids in smaller groups to prevent huge outbreaks, masking. We won't be able to have the same type of group activities and hopefully the kids can get to school in some, in some fashion. I mean, the pediatricians in the state are really hoping for that.
About colleges? Getting towards that time of year, another month or two, colleges might be returning back. Do we have a testing capacity, testing infrastructure for the college campuses when and if kids return to college?
I think that really depends on the county and your size and your healthcare infrastructure and resources. As we've seen, we still have a bit of a limited supply of testing capacity. So I think that, hopefully this will continue to increase in terms of testing capacity, and it really depends on partnerships. Local health departments are really dependent on their healthcare partners to be part of the solution, and they really have stepped up. So I guess, time will tell, and right now with the twice a week testing of nursing home employees and adult care facilities, it's been a challenge for them to go to their providers and get appointments and get testing. So I think planning ahead is going to be important.
I know I've already started conversations with Binghamton University. They announced this week they plan to open and have students back, I believe, August 26th. But they're going to do a rolling type move-in. They have a grant they've received for testing. So they've been working with both the county and the local healthcare providers to try to put that plan in place before the students come back.
We in Erie County, we have SUNY Buffalo, which is a very huge university. So we'll, we're a little bit worried about our testing capacity for to meet the needs of that university if they require all students and staff to get tested before they return.
It seems like we've 60, 70 days into this now. We've learned a lot about our public health infrastructure in America. We were exposed. We were vulnerable now to these types of mass outbreaks in ways that never before has been disclosed. If we have to do it over now, or as we rebuild, knowing what we know now, what are your thoughts on how the federal government, how the state government, how the counties can begin to rebuild this local health infrastructure. Clearly, we should be investing more from the federal government into local health departments and the capacity to test both antibody and diagnostic testing. This is not going to go away. These threats will continue. Your thoughts on rebuilding the public health infrastructure?
I would just say, you know, we've been here a long time, and obviously the spotlight's on us now. So funding is obviously vitally important to keep us going. But I think another important piece is we have systems that work. We've built systems that work. So one of the most frustrating things is when state or federal officials take something that we do and then create a new system. And now we are kind of stuck learning that new system when we do have a system that works. So of course, we'd like to see more funding. And, you know, we've been here protecting public health for a long time, and we will continue to do so. So hopefully they, you know, we'll see some funding behind that. But again, if they're going to develop something new, really getting our opinion before that goes forward.
I would agree with that. And I think that, you know, we pride ourselves on being financially and fiscally frugal. Health departments often run on a shoestring budget, and at a time when you know, on a given day we don't have enough funding to do the prevention, education, and then we need to respond to an emergency. We clearly need to support across the state and the country funding for public health departments, because you know, we're on the ground and we're here. Usually they say, you know, when you don't hear about a public health problem, it's because public health is effective and we're doing our job, but we're also doing it on very limited resources. So we have powerhouses across the state in our local health departments, and additional funding is really critical from state and from federal resources to continue doing what we do and to be flexible enough to stand up and address an emergency.
I think this has shown everybody how important public health is, how important epidemiology is, how important the public health lab is, and hopefully the you know, with our reorg, these you know, emphasis and infrastructure will be devoted to those areas, and you know, making sure that we have enough capacity in terms of, you know, PPE storehouses and keeping those up to date and making sure nothing's expired, and just, you know, always, you know, being prepared. But the emphasis is, you know, public health is always kind of the ugly stepchild to healthcare, but and I think now people realize we're very important.
What do you think it might be too soon, 60, 70, 80 days into this, the data on positive, the data on negative, male, female, race, age. Is there any trends, anything that we've learned in the epicenter of the country here in New York State that you all have seen so far on data? Is it able to help us understand the virus anymore? The diagnostic data, the antibody data, is it, how can research of this data help us better understand this virus?
So I think that I know that the state health department is doing a lot of research and data analysis, and I think that when this first started, some of those demographics were not necessarily being collected because in New York City, for example, it was happening so quickly and people were dying so fast that they, you know, the data collection was difficult to keep up with. But there is the COVID dashboard on the state health department's website, which I think provides a lot of very interesting demographic information. I think it's a challenge a lot of times at the local level to collect that level of detail in terms of who's getting tested. But I know that especially for nursing homes, that was made a priority. But, you know, we're seeing, and I think we're not unusual, we're seeing the vast majority of people who are passing away are the elderly. They're from congregate settings. But there are a lot of outliers in terms of people who have underlying health conditions who are younger. And so I think time will tell when all that data starts to get sorted out and collected and analyzed. But it's very important.
About the role of pharmacies, Walgreens, CVS's, the governor talking with retail pharmacy chains to assist in the diagnostic testing. Have they started to do that in your communities at this point in time?
We have one pharmacy that has, I think, started to research. I think they have some collection kits, but I'm not sure how many they've actually utilized. But I will say that's a smaller independent pharmacy. I have not heard much from the larger chains.
We've had Walmart have a presence in testing, and we've also had Rite Aid have a presence in testing.
So those results, are they going to the local health departments from Walmart's or pop-up testing facilities?
Through Eclairs, they are.
Well, I think that'll be it. We're right at our hour time slot here. We were able to take a couple of questions. I want to thank all of our speakers very much, not just for participating in this webinar and helping to educate folks, but all the great work that you're doing in your communities, protecting the people and promoting the efforts of the county local health departments. So again, a special thank you to the New York State Association of County Health Officials. If you have further questions, if you're a viewer of this, you can contact A. Lamont at NYSAC.org with any questions that you might have for follow-up. And again, this webinar will be posted on the NYSAC website. Thank you so much to our speakers today.
Thank you.